Hello everyone, welcome back to this special episode which follows on from part 1 video on reversing type 2 diabetes. Now you can watch this video via this link in this channel, and you'll get a background on why this is a paradigm shift for treatment of type 2 diabetes. And so in that video, I promise that today I'm going to invite a very special guest with me. Her name is Miss Liza Chan, and Lisa is a practicing dietitian based in Hong Kong with recognized registrations in the UK and accreditations from Australia. She's also a member of the Hong Kong Dietitians Association with 20 years experience in helping thousands of clients, primarily in managing metabolic syndrome, eating disorders, and sports performance. So Lisa, welcome.
Thank you, Dr. Lorena, for having me. It's so exciting. This topic is so interesting, let's just say. There's so much to discuss about. Yeah, so and I also really love your quote. I don't know if you remember, but I will quote you. You've said that diet trends are like fast fashion. Yes.
Don't fit yourself into one.
That is so true. Yeah, so speaking of the fashion, like fashion trend and then food trend and things like that, I don't know about your take, but I personally think that people blindly follow this trend is kind of like a sense of belonging, or they want to do something, everybody's talking about it, they want to experience it, but they never really felt they probably, I don't know if they internally think that it's not for them also, or they just think it must be for me because everybody else is doing it. I don't know even if it's a confidence thing. What is your take on that, Dr. Lorena?
I think it's a combination of all those things. We do want to belong. We also want something that is straightforward and simple to solve our problem. And I think that's maybe one of the reasons why there are so many different trends and fads. And when I heard about this particular bold statement from the American College of Lifestyle Medicine, that this type of approach can reverse type 2 diabetes, it was a very interesting moment, because it changes the way that doctors and health providers treat type 2 diabetes, because usually we just manage the complications. We don't often talk about reversing the disease because we accept it by default as being chronic. So that's the reason why I invited you, because I want to see, do you think this is a fad or a trend, and how realistic is this approach?
Right. Practically, in my 20 years of practice, I do a lot of weight management, and a lot of people come in because of disease-related obesity or overweight. For example, the metabolic syndrome, so your 3 highs, your high lipidemia or your blood sugar or hypertension, fatty liver, those sort of things, they come in. And they do reverse for my patient after they've lost a certain amount of weight, not just weight, but body fat. And then, so some of them, even to the point that they used to have medication, and then they're to the point that they can go off it, or at least reduce it. But there are a bunch of clienteles that, even though they've lost the weight to a normal BMI, normal fat percentage, they're doing exercise, they're eating very clean, they still cannot push those cholesterol down. For example, I bring it down to the family history, because they usually have a high family history of the heart disease. And so I said, a lot of them don't want to take medication. I don't know. I guess patient going to you, they're the two style, because you are very good. You have the background of the lifestyle medicine, so you do promote lifestyle changes.
Both of us, we work together well with patients, because many patients who come to us are very health motivated. So I know that you, as a amazing coach as well, you talk about all the other aspects of lifestyle. So that's why I think that there is sustainable long-term results, and you're able to personalize your approach. And the discussion about medication, I think more and more people are medication hesitant. Yes. Because I think maybe in some practices in different countries that medications are just given straight away and prescribed upfront, rather than giving people the option of what they actually need to do from a lifestyle perspective. Yes. And I think this is because as a physician, I never had received any training about lifestyle interventions except just eat less and exercise more. There wasn't really anything personal about it. So this is been a learning process. And I think you also have that same experience. And that's why I think we work together so well. When it comes to this particular intervention, and it's not just one intervention, it's actually, when I looked at the background of this particular outcome of the study, reversing type 2 diabetes, this theory actually did start about 20 years ago. So when you're describing the success of some of your patients clinically in reality, I think this finding in the study actually supports why this is working. But it seems that right now it's more than just the weight loss, because the type of calorie restriction for this particular reversal is quite intense. It's like 600 to 11,000 calories per day only.
Yes, so I think I don't know about your audience or other audience, do they know the definition? I think education is very important. And a lot of times when we say reverse, your mindset and my mindset and somebody else's mindset is different. What is considered as reverse? I guess when I look at titles or scientific papers, I really want to clarify the definition so that I don't think about, reversing is like completely, is it completely up, or is it just come back a little bit, or come back by how much is considered as this reversal? That's number one question. And number two is your question about 600 to 1100 calories. What I don't like sometimes of the diet trend or a lot of these protocols or guidelines is it seems like it's one number to all. Like if I was like 200 kilograms, like a football player, for example, like the rugby player, like, do I eat 1100 calories then in order to reverse my diabetes if all of them is actually muscle or whatever? So I think that if you ask me practically, it's very difficult. It's very difficult. In my practice is for people whose BMI is over to the point of obesity, it is a long road that they get from normal weight, overweight, and then to obese or obese 1 to tough thing. There has to be a lot of diet struggle in between. And then all of a sudden, you cut the calories to 600. Like me just thinking about 600, I already feel hungry, to be honest. Like, it's very hard, and it needs a lot of motivation, which I think your study paper also said. The person needs to be mentally prepared. This is like clench onto your teeth, you give all the energy to sort of restricting yourself to this little calorie intake.
Yeah, you're absolutely right. So I think what we might need to distinguish is the results that you're getting from weight loss versus that these group of patients in the study, and there were two different studies. One was actually to highlight what was actually going on in these type 2 diabetic patients. And so there 20 years ago, they came up with this hypothesis because they found that patients who were very obese or living with obesity, they had bariatric surgery. So when you do bariatric surgery, you take out a part of the stomach, so it shrinks it and you're eating less. But the interesting finding from that paper or that research 20 years ago was within a matter of days, these patients had normal glucose levels within days already. And that was even before significant weight loss occurred. And so some of the researchers 20 years ago started looking at this, and they came up with this idea that the excess calories that you eat immediately actually gets stored as excess fat in the liver. And as a result of the excess fat in the liver, it actually also got stored in the pancreas. And so the pancreas makes insulin, and we can see that some of the pancreatic cells that make insulin was impaired at the time. And so they actually then proved that if they were able to completely cut the calories, and this is similar to what happens before surgery. So you and I, if the audience has ever been in surgery, you can't eat anything the night before, right? So you have to fast for 12 hours. So literally there was no food. So what your body does is that it mobilizes stores, and the easiest place to actually get energy from is fat stores in the liver. So they found that what was happening was because these people weren't able to eat before surgery, and after surgery, they were seeing the effects of basically no food for 12 hours. And that was the effect that they identified. And so they went on to get funding to prove this. And then they also did some special MRIs to look at what was happening to the fat in the liver and the pancreas. And they found that literally within 7 days of this very restricted low calorie, because you can't eat straight away after stomach surgery. Yeah, as you know, you've probably been in hospital to see these patients. So they can't eat anything. And then they found that they didn't need their blood sugar medications anymore because their glucose was normalized. Now, the definition that you asked before, what is remission? So this only recently came sort of to an agreement. And remission for type 2 means normal blood glucose and average hemoglobin A1C without any medication for at least 6 to 12 months. And that's what we call remission. Yeah, so the idea was that this excess fat that was in the liver and the pancreas could be reversed immediately by reducing drastically the calorie intake and basically restoring glucose function. And then they actually went on to do, so within those 8 weeks, lost a significant amount of body weight or body fat. And then I think what we kind of see is this effect. I think going back to your question, 600 calories a day is really, really difficult. 700 is not too bad. So it's between 600 to 1100. So there's this sort of, I suppose, buffer. But that's different to say, what you said before. If I were someone who had a higher body fat percentage and I reduced my calories by say 500 to 600 a day, I would still lose weight, but that's more gradual. But I could still be in a surplus for my body, because now we realize that some ethnicities, like for example, South Asians, they can have normal BMI, but they can be insulin resistant. So their weight might be normal, but they actually at the same weight are more prone to store the excess calories viscerally, so around the liver. And it seems that these normal body weight types are much more predisposed to diabetes in the future. So those are specific situations. And you mentioned genetics, and I think this is where there's no one size fits all, right? Like it's fast fashion.
Yes. Because this is very interesting. You show me the paper. To be honest, I haven't really dwelled too much into it because I want to discuss it with you now. Like with this 600 to 1100 calories, is there like a protocol for who can fit this category or anybody? For example, if I was obese, in order to be obese, I'd probably be eating like over 4,000 calories a day. For example, 4,000. It's actually not surprising. Some people might be surprised, wow, 4,000 calories. But when you think about a Big Mac meal is already like 1,000 calories, 4,000 calories doesn't seem to be that hard if people keep on snacking and things like that. So if I was on a 4,000 calories diet, for example, and then I just say, let's just choose 1,000 for a easy calculation. So the deficit, 3,000 calories per day. And then in order to lose a kilogram is 7,000 calories, right? So in 2 days, they would be losing a kilogram. And then like in the whole week, they will end up losing like 3-4 kilograms. So a question mark, is that a healthy rate of fat loss? Is my number one question when I think about it. Let's not talk about the practicality. And also like, for such a sudden calorie deficit, will our body choose all fat, or will they end up choosing some muscle as well for the calorie deficit to maintain the metabolism? Because for somebody who's very obese, a lot of people, that's a myth. They think that the metabolic rate is low. In fact, it's not. The metabolic rate is quite high because you just think about how much energy you need to push that brick or that like 100 kilograms brick, right? So the metabolism cannot be that low. Like burning calories cannot be that low. So every day they need to push that 100 calories brick everywhere they go. So that's just my question. I don't know if the study did actually say anything about that.
So I think what the study then progressed, I think it wasn't in the same, but well, they actually followed this group of people. And then after they actually had normalized their blood sugar and the medications were deprescribed, they actually transitioned into a maintenance phase. Because I think your point is, it's probably not necessarily sustainable long term.
Yeah.
And I think safety mostly has to do with if they're still taking their diabetes medication, they need to see a physician to have it deprescribed. So that was also part of the process. And I think what's also important is that they had guidance during that 8-week phase, because they were also able to eat non-starchy vegetables. So I think that was part of the study, and they showed that in those people, one of the studies actually at 100% remission, and then the other study, I think it was 40% remission. So it depended then on how long each person had diabetes for. So the shorter your diagnosis from diabetes, the more successful these people were. So part of it was that when the actual excess calories was reduced, the pancreas was able to recover its own insulin production. So this particular method wasn't so much about the weight loss, it was actually about helping the pancreas to recover beta cell function. As soon as that occurred, they didn't need the medication anymore. So I think it was less about the actual weight loss, but it was more about, like you said before, we think people living with obesity actually have a low metabolic rate, but actually they need more energy to sustain their body mass than someone who's actually within a normal weight. It was a dramatic deficit compared to what maintained their body weight. So I think that's why it was interesting to me, because long term, I think that's really where the exercise and all those sustainable habits come into play, because if you don't maintain that, then you can actually go backwards. You can actually get diabetes again. So this remission is not a cure-all, right? Like it's you do this for 8 weeks and then your blood sugar is normal and then you don't do anything else. But that's not really the case. I guess like the way they also did this diet was using a whole food plant-based diet. And I think one of the reasons why they actually chose this was maybe because they also understood that there were other benefits from having whole foods and benefits from focusing on more of a plant diet. Do you think that's a reasonable approach?
Yeah, because that was the next question I was going to ask. 600 to 1,100 calories. Is there a macronutrient makeup? For example, is it a high calorie, low carb diet, or is it like a keto diet, or what sort of diets that it is comprised of? And then now that you mentioned about the whole food plant-based diet, now this type of diet is more like a vegan style diet. So you use everything that is not animal products. So the problem with this vegan diet, okay, let's talk about the good thing first. If everything is high in fiber, not that your gut microbiome is going to be good, and also it will make you satiety, so it makes you fuller. Okay, so that will make that 1,100 calories more tolerable. You'll end up having a relatively more substantial food. However, the problem is if people who are on such a low calorie diet and they don't have somebody professional to follow them on, or they don't know what they're doing, they might end up getting malnourished. Why I say that is clearly protein is a very important nutrient. A lot of us know about that. And with plant-based diet, although they all have some sort of protein, but the amino acids may not be complete. So what is complete protein? Complete protein means a bite of that protein will have all the amino acids your body needs. So amino acids, a lot of laymen's or the general public, we think it's just muscle. But in fact, different amino acid has its unique function, not just muscle building, not just muscle recovery. It could be making enzyme, could be making hormones. It could be making our immune system cells. It may be like a transporter. So it's a lot of function inside our body require amino acids. And it's not just one type or two type. It's all the essential amino acids that we need to ingest, which make complete protein good quality. The only plant-based that is a complete protein is soy products. So you can eat your tofu. But then you have the question of if these patients are youngsters, there is that phytoestrogen, that eating too much soy products, they might end up having too much female-alike hormones.
Well, I can bust that myth because actually, I think if we are eating soy as part of the traditional way instead of as a meat substitute, I don't think there are any harms in the sort of plant phytoestrogens, because interestingly, the plant phytoestrogens actually have a protective effect on breast and bone tissue, and then they actually have less of a cancer-causing effect. So they actually do, if you're eating it from sort of how like Asian people generally eat it, it's probably completely okay. I think the question is when we solely rely on just that.
Exactly.
Protein.
The quantity, again, it's the quantity that matters, right? So that's why I'm saying if people don't know how to mix and match their diet, or a lot of times what I observe is our general public, whenever they hear something is good, they go all in. But they don't know exactly what to do yet. They just have their own mindset. For example, you just mentioned whole food, plant-based. They will just say, oh, plant-based. And then they don't have the concept of, do we have enough of the carbs, the good fat, and then the complete protein. They wouldn't think it like that. They just take the title as in, and then do whatever they feel comfortable, which that's why I'm saying that's only my concern is the balance. You already have a very small calorie intake, and if it's not balanced, then because it's a long road, right, this reversing, and you said it's at least 6 months to a year and things like that. So if they keep on not eating enough of the nutrient, their whole metabolic rate may slow down, and I don't know what the outcome would be, but it's definitely lethargic and things like that.
Yeah, I don't necessarily think that the low calorie is for that entire 6 to 12 months. I think definition of remission is 6 to 12 months, but I understand that the actual intervention was 8 weeks only. So after 8 weeks, obviously for me it's obvious, but not for everyone necessarily, but after 8 weeks, you should be transitioning to a maintenance phase, right? Like you've got the intervention phase where you're creating that environment of very low calories, your blood sugar normalizes, you don't need medication anymore. And yes, you're going to get some weight loss, but then afterwards, it's not so much about losing more weight, but it's maintaining that metabolic health. So maybe the calories need to come up and go back to a maintenance baseline. And if that was the case, I think, even continuing on, people still need to, from the beginning, be educated, like you said, about what is actually healthy, adequate amino acids and protein intake, right?
Yes. That's a very interesting point that I want to ask as well. Okay, so after 8 weeks, for example, if it was an obese person, and then after 8 weeks, they may lose 10 kilo, for example, then they can go back to a maintenance stage, or should they still get their weight management down so that they can, or is just about that 8 weeks of calorie deficit and then it should be okay? I
think that's a very personal question, right? Because I think that it really depends. Again, it might go back down to this idea that we all have a fat threshold, which is the amount of fat where it's healthy and you're not going to become insulin resistant. And I think that's different for each of us. So then we need to find out what that is, because then you need to kind of have ongoing monitoring to see whether or not you go over that fat threshold. So even in some of the studies that actually measured people after they came off the 8 weeks and then they went to just like, natural eating. So they measure these people at 12 weeks, 4 weeks after the intervention, and some of them gained around 3 kilos. And then there are a proportion who were able to sustain the normal blood glucose, and then another proportion that had impaired blood glucose, and then another portion that kind of reversed. So what I think is that that's a very individual long-term outcome. So I think when it comes to that long-term, perhaps we actually need to think about individualizing it more. And this is where I think the idea that you've achieved a certain goal, you might need to reassess your intake so it becomes sustainable. Because the other thing also is when these people were doing the intervention, they allowed them, if they weren't exercising, it didn't matter. If they were already exercising, then keep it as it was. So the exercise component really didn't play a big role. But you and I know that for long-term weight maintenance and for metabolic health, we do need to actually improve our cardiorespiratory fitness and also muscle fitness. Because the other point I want to make is long-term, our muscles are actually a storage house for dietary carbohydrates. And, as we get older, we lose muscle. So I think we kind of need to think about it long term. And this is the reason why, there are all these other diets, like low carb diet, low GI diet. Like what are these actually doing? And I want to sort of get your perspective on, what the pros and cons are of these different strategies.
Yes, definitely. That's a very good point. I think for one comment for how you say the fat threshold, I want to make a comment there. I do have some clients who are quite overweight, and they have got no medical issue. That is, and then everybody will be saying, well, then that's great. Like, they have no motivation. So they think, I don't have any problem. And then you can't motivate them to have a better health. So I don't think a good fat threshold is that good to me, because then people are not very motivated to get them back in shape. It's not just the blood sugar. It could be obesity itself. In Hong Kong, it's not, right? Or is it everywhere is considered as a disease? Is that a disease on its own without any?
I think from the medical perspective, it's considered a medical condition that is chronic and does need lifelong management. Now, like you said, not everybody living with obesity is going to get diabetes, because we do all have a personal threshold.
Yeah.
However, it's not just metabolic health, it's also joint health and bone health. So, higher incidences of back pain, issues with knees, and also cancer, right? Like, that's also another risk factor. And so it's not just a metabolic aspect. And unfortunately, that seems to be more visible, but it's also for future health. And we know that people living with obesity don't generally live that long. So there are other aspects to it. And perhaps I think ultimately, then that becomes the reason why is important, what is important, and why should they invest in this strategy for their future health, right? So, but having said that, there are some people who go, I don't have a very high fat threshold. So, they kind of might complain and say, oh, that's just my genetics, so I shouldn't care anymore. I'll just take the medication because it's just my genetics. Yes. I also, have to be the devil's advocate and say, okay, I have a low fat threshold, so I'm just going to get diabetes anyway. I may as well not bother. I'll just take the medications because these drugs these days are so good, right? We have now GLP-1 medications, so why not use that?
That's a good point. Like, people go for the shortcut, and and then I diverted you. And back to your question about like the different style of diet, the different eating patterns. What are my thoughts? What are my take? And then how is it going to affect that muscle building part? So, okay, before I got distracted too, I was just saying, a lot of people, which rightly to believe they want to have more muscle, not just because of functional good, because of increasing the metabolic rate so that they can eat more. Some of my clients just have this motivator. But I think muscle has more than giving that we can eat more and burn more calories functionally. And then, as you mentioned, like storage, and then it's got a lot of good quality that we need to preserve. As we age, a lot of times, if we don't keep moving, so muscle, you need to do the movement to maintain its structure. And if you don't use it, it will just flop out and it doesn't have its strength, and then you will become very tired, and hence you just have no motivation at all. The question is, what is the magic macronutrient makeup to maintain your muscle mass? That is the question. Now, that is very tricky. I'm a sports dietitian myself. You need to fine tune between not too much, but you need to have more than your normal calories, because you're building muscle. If you're building muscle, you build anything, you need more calories. You lose fat or lose anything, you cut calories, okay? That's why when people go on a weight loss program, they will lose some muscle mass. That's inevitable, but it's all about the proportion. And also, I always say, if people want to lose fat and gain muscle, I say these two processes. I usually do the fat loss first and then the muscle building, because when you lose weight, unfortunately, we can't tell how much fat to lose, how much muscle to preserve. That is a lot of trial and error. And it's not just playing with the nutrients, it's also your lifestyle. Are you sleeping well? Are you stressing? Are you doing the meals properly and exercising well? All of that comes into the equation. So it's not as easy as we say. But if people go on low carb diet, what's going to happen is we will need glucose. Where do we get glucose? So you can get glucose from your fat storage, which is very ideal. But we also, our body may prefer to use muscle to turn into glucose for our brain, for our important cells. So then you will be depleting the purpose of building muscle if you go on a very low carb diet. But back to that, at the very beginning, I was saying that people don't know the definition. A lot of times when we hear a low carb diet, I want people to start thinking the definition. What do this person telling me low carb mean? Not what I mean, okay? You need to know what they are trying to teach you. So what is the definition of a low carb diet? It's actually not as low as people think. So supposedly all around the world, different countries have different recommendation of the macronutrient, ideal macronutrient compared to your total energy intake. So carbs is between 45% to 75%. Hong Kong actually say up to 75%. So for people who don't exercise or already on the older side in age-wise, they're taking 75%. That is just too much. They are going to become stored fat. Anything, not just carbs, protein, fat, any nutrient that's over, it'll become stored fat. So that's the number one.
That's excess nutrients versus what you're actually metabolizing.
That's right. Anything. It's not just carbs.
Yeah, not just carbs, because you can overeat fat too. You can overeat fat too. So people doing low carb thinking that helps them lose weight, but they're actually overeating fat content because you have to substitute, right? Yeah.
That's why I don't always like to prescribe by calories, because when you prescribe by calories, people choose their own like, right? Which is not going to work. You eat too much of the fat. That's the wrong nutrient for your body. You eat fat in, it will take a long time to make into our energy unit ATP, but the glucose will give you instant energy. So you'll be more energetic, you'll be more powerful type of energy system.
Yeah, so it also depends on how active you are during the day. Are you also training for a purpose? So do you need the energy for performance in the gym so that you can actually get the most bang out of that training process? Because I think the mindset used to be you exercise to burn calories, but actually, you know, when we talk about long-term sustainable health, you exercise to maintain function and metabolic health.
Exactly, yeah.
And then the other times outside of that, to actually improve your body composition, then you kind of need to look at the nutrients, and then that macronutrient portion is going to depend very specifically to your lifestyle. And this is kind of, I think, where there's no one magic diet, right? Whether it's low carb or, you know, I mean, I think these kinds of things are somehow trying to bypass a dysfunction in your body rather than actually treating the root cause.
Yeah, so I hear sometimes on the internet, even like very scientific person will give recommendations saying it doesn't matter what your eating pattern is as long as you're calorie deficit. Now that that statement to me, I don't really like. As I said, then, well, can I just eat McDonald's whole day and just get my 1,000 calories? That matches, right? So, I mean, some people like you and me might think, well, really? Or some people might think, really? They're that type of people? I say, really, they're that type of people. Yes. I've got asked that question. Can I just eat 1,200 calories on whatever? So it's amazing. People will just do whatever to their liking if your guidelines is not specific enough. So a lot of these eating patterns, the downfall is sometimes it's hard to give a specific instruction for a general public. So us general public need to be smarter and understand these are just guidelines. They may not be for me. And in order to know if it is for you, you need to go to the GP, go to some doctors to make sure, know what your health status is. Do you really need that eating pattern? Is that eating pattern is going to do more harm than good? All right. And then you check out all of those things, and then you choose one that is sustainable, not one that is so, I can lose so much and then what? You need to, as you said, Dr. Lorena, we need to think about and then what? The long term, not just that moment. Like, for example, your intervention is just 8 weeks. We're not just at 8 weeks. And then what? You need to keep on questioning. And then what? If you go back to what you were before, you will be what you were. Then it's kind of like, you wasted that 8 weeks.
Well, I think there are two ways of looking at it. I think when the American College came out with this statement that it should be offered first, I do agree that we should also be addressing the lifestyle aspect. But I also think that it wasn't just about the 8 weeks. I think there was this ongoing maintenance phase that has to also be adopted, because remission is lifelong. If you go back into the metabolic dysfunction, then you start having the toxic fat build up in the liver and the pancreas, you're going to, again, go back into what you were before. And I think, this is why some of these interventions may work better if they are, if the person's already motivated to make that change. But then they also need to be guided, because, short-term success doesn't actually ensure long-term sustainability.
That's very right. So ultimately, I think everybody needs to know a lot more what they're about to do before jumping into doing it. Because I think that's the thing. A lot of people just hear the good thing, the good part, but then they never really dwell inside and think about, am I able to do it? Even 8 weeks for Hong Kong people, even some of my clients, tell them to eat clean 1 week. They want to die. They really, I can't go out, I can't drink. So this is like 8 weeks, guys. It's not even 8 hours. 8 days, that's already too much. Sometimes we think it sounds easy. Oh, it's only 8 weeks, 2 months. But really, you look back at your own history, previous history. How long can you sustain a very restricted diet? Let's not talk about 1,100 calories. Any sort of restricted dieting or any restricted anything. How are you able to do it? Because sometimes what happens is, I discovered with any of the eating pattern that you mentioned, a lot of them is pulling out something. And so what happens is people feel very deprived, and then they will have this emotional buildup and then go into binges. So that is the downside of any of those restricted eating patterns that is not suited for you, because then you restrict, and then one day it will explode, and then you will get into this diet cycle, which is a disordered eating pattern. Sometimes, often people will get into when they started these sort of restricted eating patterns.
Yeah, I think that you're quite right, because sometimes we uncover through the process of working together that some of our patients actually do eat emotionally, because they're gaining weight. They're also managing their household, their careers, their family. And so there's a lot of stress. And then, now we are living in a society where food is readily available and very tasty. They've hacked it. They found the right combination of food that's super tasty, and they are calorie dense. It makes us want to keep eating it. And it's a way for coping with stress. So maybe it's not to the point where it's a DSM diagnosis of an eating disorder, but it's disordered eating, like you said. And that itself can actually sabotage that journey. So when you are too restricted to your own tolerance and you don't have a way of managing that, then I think you do become trapped into that cycle. And maybe some of us, like for some of our patients, they need to go and see someone else to find a better strategy that doesn't involve food to cope with their stress. So I totally agree with you. The idea that, it's just calories sounds really simple, but to actually put it into action is quite complex. And one of the things you mentioned before was sleep deprivation. And one study that comes to my mind is if you've been sleep deprived and you sleep 6 hours or less, you're probably more likely to eat 500 calories more per day. And that's significant amount. If you're doing it every single day for a period of like even 2 weeks, you're gonna see the excess calorie intake, and it's gradual, because some of these metabolic conditions like type 2 diabetes actually takes decades of your body to compensate for it. And then as soon as it gets to a threshold, then your blood sugar suddenly goes up. So a lot of people think that it's a sudden diagnosis, but actually if you looked at their blood sugar at baseline over decades, it's been slowly creeping up. So I think the fact that you don't have a condition now doesn't guarantee that you won't have in future. I think there's a lot of ethnicity and lifestyle that comes in the background. So I think what you're saying, I'm totally on board with. Is there anything else that you think people should know about before they go into something that's so intensive? And if people are open to that, what should they look out for when finding a health professional? And for people who don't really do very well with that type of restriction, do you think there are other ways to achieve the same result?
Okay, I'll answer your last question first. I think, as I said, we all should be very aware of our personality, our environmental factor, like how supportive is our environment. For example, if the 1100 calories, that is going to be very restricted. There's no way you're going to be able to eat out, probably. And then if you're going to end up eating like a Mediterranean style or the whole food plant-based, you just need to cook yourself. Now, do you have the facility? Do you have people to help you do it? Okay, you say, I have a helper. The question is, are you willing to bring your lunchbox to work? And are you willing to don't go to those happy hour, don't eat the snacks and things like all the temptation? You need to do some questioning whether you can do it or not. And if you really think you can, I think you should trial out just 2 days. Not to 1100 calories yet, just to bring your lunchbox in, or just follow something very strictly and test yourself. You need to see if that is going to be practical. And then if you really think there is a need, the doctor said you can do it, and then yes, I am all motivated. I did 2 weeks of home bringing lunchbox or whatever. The 1100 calories, if you were going to do it, who should you turn to? Definitely somebody registered. Now, we need to understand Hong Kong has no regulation in dietitian, so anybody, like the English dietitian is probably less used, nutritionists. Nutritionists are not supposed to give out any meal plan, especially if this is like disease related. You want to do this because of reversing diabetes. So you need somebody who knows what they're doing and know when to stop. You can't just keep on pushing. You need the monitoring system. And if they are going to do it, and you found somebody registered, you need to make sure, I personally think, that 1100 calories, you still need to be balanced. You still need to have your basic, your carbs, protein, and good fat, and then your micronutrients, your calcium, your iron, your vitamin complex. And if all is not possible, then supplementation is possible. But then supplementation, you need to make sure that you find one that is reliable. because again, there's no regulation on supplementation. They say 1000 mg calcium. You don't know whether it's calcium, and you don't know whether it's 1000 mg either. Like, people blindly trust them. You don't know, okay? Or contamination. Okay, so you need to find somebody registered. You need to make sure the diet is balanced, and then you need to look out for supplementation. The best way I like to do such a very low calorie diet is everything with calories. So meal replacement, or even things that has food labels. Because when you go to fresh food, even though you go to the most accurate, like USDA food data to find how much potato calorie is, the potato that they listed is the potato that from America bring to them. You don't know if that is the potato that is from your supermarket, from Hong Kong, from China, or from Australia. If there may be a little difference. If it's just normal eating people, that little bit of difference is not a concern. But if you're on like a 600 calories, if it's only a 20 calories deficit every 50 grams or something, then, you know, it kind of adds up, and it might not get you to where you are. So those things with food labels, because food label, the calorie content is by law. So when they have a food label with the calories and the 7+1, the macronutrients, it has to be that, or else you can go and sue them. So that's why you
have to be more precise the lower your calorie intake, right?
Yeah, exactly. Because otherwise, you may be thinking you're eating 1100 calories, but then maybe a little bit here, a little bit there, you may end up eating 1300. Right. Just a couple hundred is very little. A couple of hundred calories is very little. But then because you're only doing it for 8 weeks, if every day you are 100, 200 more,
it could be very easy to overdo. And I also think that when we're talking about like whole foods, sometimes people often underestimate the portions, because they don't necessarily understand that, you can eat whole foods and you can make your own whole foods at home. And often what I see is some patients say, I eat everything whole, I make everything myself, but I'm still not losing weight. But what they're doing is they're actually eating dates together, a special recipe of dates with nuts and a cup, dark chocolate covered, combination, and that's already easily 200 calories. You eat one of those, that's already 200 calories. And eat two of those, that's probably 400 calories, right? Yeah. But if you actually fruit or orange on an apple, that's equivalent to having 5 oranges. No one eats 5 oranges, but they're also whole foods. But then again, it also matters, right?
Yeah. And the most easily added calories is nuts. Nuts are healthy, it's good fat. But then that little handful is
a whole packet. You eat a whole packet of nuts, that's 1,000 calories.
Yeah. So that's why when you think about it, a lot of people say I eat healthy, and then you look at the diet and it is healthy food. They may even be on the Mediterranean diet or the whole grain plant-based diet, but why are they still overweight? It's all about calories. So back to the point, I say we need to count calories, but we also need to know the makeup of the calories is balanced. So it's two things, and you can't just take one out and say which one is more important. That's a lot of people like to say, which one do you think is more important? If I must just choose one, what to choose? I don't understand why people like to know those answers, because it's I don't know.
I think it's doing one thing at a time, like you said. Test out whether or not you can actually be consistent, right, with this particular choice, right? Like, I think every diet works as long as you can be consistent with it. So it's finding one thing in that plan that you have and seeing whether or not you can be consistent about it. And I think sometimes you do need someone outside of yourself to look at things professionally, not to judge you, but to take a look and go, well, maybe this is an area you can improve, or maybe this is where you can try to be more consistent. And then just, I think, redirecting the focus on what actually is going to work best for the person. So that's why that, personalization, that coaching aspect that you bring is so important, because we're not just looking the short-term success, but we also want this to be something sustainable, so that we can get the full benefits. Yeah, thank you very much for answering that question. Yeah, so the other thing I also want to add finally is because people are taking medications and they're very, very low calorie and they become normal in terms of their glucose, they still need to work with their own physician and their own doctor to actually de-prescribe these medications, because there are many different types of type 2 diabetes medication, including insulin and also the newer drugs. And I think it's important that the physician is also helping them de-prescribe, because you can't stop everything at the same time. So having a physician monitor you closely during that intervention phase is critical. I do really highlight that it's important to have a multidisciplinary team that's working together to support you through that process, especially for people on meds.
Yeah, definitely. Those patients that I mentioned before that they lost the weight and then can go down the medication, every time they do it, I tell them, you make sure you have a data recorded for the whole month, like your blood sugar or when you're doing finger prick, and then show it to your doctor and then make sure everything is okay. And then they do another test. Then they decide, not us decide, because everybody has different risk factor. Those numbers that you see on the blood report may not be the numbers that you need to target. I'm sure every doctor will look at the medical background and then give you your number that you should be aiming for. So all the patients that come in, I always ask them, what is the number that your doctor aim for? Then we work around it. It's not the other way around. It's not by Mr. Google or by theory. That's too generic. Yeah, I think it's personalized, everything.
Great. Thank you so much, Lisa. Thank you so much for your time today, for sharing your expertise, and also highlighting that even though the concept seems simple, that the actual practice of it is much more complex, and that we should all find a way that works for us, because what's out there, what's trending may not actually fit you, but maybe there is a way to tailor if that's what you choose to do.
Yes, that's right. That's right. There's always some solution.
That's okay. So thank you so much. I will hopefully get to invite you again to this topic, Lisa. And if anyone wants to follow Lisa, she's also on social media. I will post a link down below so you can contact her and you can follow her. She always has great, amazing practical tips and advice, and also in Cantonese. So if you're living here in Hong Kong, she's my go-to person because we all like to eat out. And she's got amazing tips for you to share. So thank you, Lisa. I'll see you again soon.
Thank you very much, Dr. Lorena. See you. Bye-bye.